Hey everybody, how's it going today? This is Adam Idso. I'm here to look at our discussion one for module four. For this one, I decided to look at the second question, which was concerning medically assisted death, as I thought it would pose some interesting thoughts, and I'm looking forward to hear from you guys as well. Um, so just getting right into it here. In most cases, I think medically assisted death is ethically justifiable. Most often, those cases involving relentless suffering. I say most because many of the arguments against it get into the slippery slope discussions concerning the competency of the patient and not having given this topic its rightful dues in regards to research. I only gave it these last couple of hours here looking into the question, and I feel like it deserves some more respect for that. Deserves some more respect for that. And having said that, I'm not well equipped to adequately defend my position on that front. However, when pondering this question, I thought it would be best to put myself in a hypothetical situation in which I am a healthcare administrator, and a doctor came to me with the question, what should I do if a patient asks me for assistance in dying? And after some careful consideration, I came to the conclusion that my answer would sound something like the following. Among the most critical aspects of responding to an assisted dying request is being respectful and compassionate. Nearly every request reflects a traumatic event for the patient who may have been agonizing about his condition and the ways out. The requests of the patient should be explored in order to better understand its origin and to determine if there are other interventions that can help to improve the motive for the request. This includes motive and degree of suffering, psychosocial support, and degree of patient understanding. From there, if a patient's request for assistance in dying persists, each individual clinician must decide his or her own position and choose a course of action that is ethically justifiable for them. On the other side of the argument is the patient, of course. Byron and Soren submit, and I agree with, that the important thing from the patient's perspective is that the plans of treatment are in their own interest, whether or not the patients give consent. In cases involving patients who are incapable of giving consent and hence of having their consent honored, respecting consent is irrelevant. The patients cannot consent to any competing plan of treatment. In cases involving patients who are capable of giving valid consent, honoring consent is a useful marker of the patient's interests as determined by the patient's own values. Finally, the same article poses an important claim for reframing the debates around this issue, and I believe it is something that needs to come into conversations regarding this debate at large. That is, the debate should be reframed in a manner that emphasizes rather than obscures the obvious but ignored fact that it is someone other than the patient who is performing the action. It is the physician, or that is the physician. By moving the focus from the patient's expressed desires towards the patient's values and interests, expressed or otherwise, and the conscience of the provider, I would imagine the debate regarding the morality of euthanasia will change. In effect, they submit, it will become standard to consider the effect that ending a life could have on the healthcare providers who participate while they care the patient to death. We hope this will bring discussion of the importance of protecting the conscience of the providers into the mainstream debate. And as a future health administrator, this is obviously of utmost importance because care providers' interests of autonomy and integrity are at hand. Alrighty, guys, that's it from me. I look forward to hearing some of your guys' arguments, as I know a lot of you are working directly with these patients, and I look forward to hearing what you have to say. Thanks. Bye.